we have a special guest speaker from the University of Manitoba that we are going to have a great conversation with. But the team and I would like to take the first couple of minutes to just briefly pause and talk about the series that we launched this year called Humanity and Healthcare. This is the face page from the website on the Queen's Faculty of Health Sciences website. And it's been a real privilege this year for us to share many stories and conversations and questions and concerns on many different topics. We talked about doctor as person. We talked about a nurse practitioner finding a unique role. Jane talked to us about the unexpected detours in life and career. We had a COVID check-in. We talked, one of our team members, Hugh Wiley, and one of his physicians talked about his injury 10 years ago and some of the challenges along the way. The opioid epidemic, COVID check-in, Indigenous medicine and practicing in your own community. Terry Landry just last month spoke to us about trying to help patients live their own life in the community with those with mental health issues. And I think that captures everybody that we've talked about. And it's really been a great year. And our mission, as you see here, collectively has been to essentially try and create a space for us to come together. Zoom has certainly allowed us to be able to do that from our homes, from our offices, and elsewhere. Promote a shared model for continuing professional development and development along the training continuum that's inclusive, and certainly look at our healthcare systems and recognize and reflect on how we can go forward and what we can do better to build diverse, equitable, and inclusive care teams. And each time we come together, it's important for us to realize where we're meeting. So I'm grateful to live and come together with all of you as an uninvited guest upon the traditional territories of the Haudenosaunee Confederacy and the Anishinaabe Nation. Thank you. So it's been quite the year, and actually it's been more like, I guess, 16 months or so. And we've all faced many stresses, many challenges, and sadly, much trauma with our patients, with families, and as caregivers. COVID's changed a lot of our lives and our world. And hopefully we can move forward together. We were talking as a team just before everybody joined us about the excitement of vaccination and the hope sort of going forward, and it really quite positive. But events in the last few weeks have shown us that there still is a lot of hurt in the world, and we just wanted to take a moment to talk about a few weeks ago the finding of the remains of the 215 children in an unmarked mass grave on the grounds of the former Kamloops Indian Residential School. Was announced by the Tecumseh Seclement First Nation. It's really hard to find words other than the word horror really comes to mind. And one which calls us, I think, to action. And then, sadly, last week, there's a horrendous attack occurred in the London, Ontario area where three generations of a Muslim family were targeted and killed. And so it's really been, there's been a lot of really tough things to think about and reflect on where we fit in as humans and as healthcare workers. And the team, we asked if Dean Philpott, if Jane could sort of help us talk a little bit more and have a moment of reflection. So Jane, I'll turn the mic over to you.
Thanks, Damon, and hi, everyone. I've been looking forward to this event for quite some time, knowing that Dr. Horton was coming for her talk, and I can hardly wait to hear all of the wise things that she's going to share with us. And this is the culmination of a really great year of programs that Damon and the team have put together on this topic. Damon asked me specifically to just think about this moment in time that we're at, where after a tough period of pandemic, we've had these multiple assaults on our senses in terms of being awakened in a way that perhaps we haven't been as well as we should have in society, about realizing the horror of the genocide that took place as a result of the Indian residential schools policy of our government, and coinciding with the terrible apparent terrorist attack in London. And I think it's left us really feeling broken. And we always were broken, but I think we feel that brokenness more than we have. But I think that many of you have, reflected on what brokenness does to us. I mean, this whole series talks about brokenness, right? And to realize, there's a saying about the fact that when your heart's broken, those cracks are what lets the light in. And so I'm hoping, especially as we go into Dr. Horton's talk, we'll really let ourselves be broken. This is a place and space. I know when I was last with you, I shed a few tears. It's a place where it's okay to admit our brokenness, and to admit that we got some really horrible stuff in our past as a society, as individuals. And the wrong thing to do is to turn away from all that and to deny that it happened. And even worse, to be ignorant about it. Right here at Queen's, we've got some really abhorrent parts of our history. We admit to the fact that we denied admission to Black medical students for 100 years. And that was absolutely wrong. And there's no question that the things that we've learned about in the last week or so, or we've thought more about in the last week or so, are horribly wrong. But this is a point in time for us to choose a different path forward in the future. And I think I am sensing that people really want to know the truth, that people are tired of denial, they're tired of ignorance. And they want to say, tell me more, tell me really what happened. I want to know. Everybody has a right to know. And we're not going to deny it. We're going to actually figure out how to do better. And I think, Damon really got to the heart of it when he said, it's got to have action. We are done with words alone. We're not going to be the people who say that we want things to be better and aren't willing to take the courageous steps to be better, to support one another to be better, and to support what some have been calling a shift in power. This is a time where the power structures that we've allowed to perpetuate violence against certain groups in society, where we've allowed the denial of the rights of Indigenous peoples to go on and on and on. We're ready to see change, and we're going to, I think, collectively as a group here at the Faculty of Health Sciences and the Kingston community, we're ready to we're ready to do better, be better, put some actual courage into our convictions. And I think that tonight's talk is going to be a real important step in that turning point that we're taking together. So let's accept our brokenness and let's try to heal collectively and move forward in a positive, cohesive commitment to the truth and reconciliation.
Thank you, Jane. Thanks a whole bunch. I'm going to screen share again, everybody. Okay. Everybody can see that okay? Yeah, great. Without further ado, let's welcome Dr. Jillian Horton, who is not so much a speaker with us tonight as we're going to have a conversation together and talk a whole bunch, and hopefully lots of people have lots of questions and insights. It's important to recognize that we as a planning committee don't have any specific disclosures or conflicts of interest. And I think after many months, most of us are fairly familiar with Zoom. Please use the chat function. We'll be scanning that. Please use the raise your hand function. You'll be able to unmute yourself when we have a question and answers together. Probably the one that we forget to do is we start talking and forget to unmute. So we'll all be on the lookout for that. And so Dr. Jillian Horton, what can I say about Dr. Jillian Horton? She is many things. She's a mom, a sister, a daughter, a spouse. She's also a physician of internal medicine. She is a national best-selling author of late. She is a prolific writer and thought leader. Academically, she's the associate chair of her Department of Internal Medicine at the Max Rady College of Medicine at the University of Manitoba. And as well, she's quite involved in the Humanities and is the director of the Klass Humanities program. She is the lead of the National Arts Center podcast for arts, medicine, and life. And I have been certainly watching and chatting with her of late, and her book, which you see the picture here, is really a great read, and there is a lot of vulnerability and truth, and Jane, I think, perfectly connected us to what we're going to chat about tonight. So welcome, Jillian.
Thanks so much, Damon. It's an absolute pleasure to be here with all of you.
So Jillian, I thought that I might ask you a couple of open-ended questions to sort of start off, and then I'm going to step back and let other members of the team and the audience ask questions themselves. I'm going to stop the screen share here so we can all see each other a little bit better. And so I guess the first thing, Jillian, in reading your book and getting to know you, one of the things that I'm quite intrigued about, and it's where your book opens, the start sort of your journey, where you frame where you're going, where you're at, of being a medical school lead and student wellness and all the fantastic things that you're a part of, that at the same time you found yourself struggling a bit, and I'm just wondering if you could help sort of, for those that haven't read your book, sort of frame that beginning, that part of the story that sort of led to you writing a book and going to Rochester and then writing a book.
Yeah, thanks for that question, Damon. So as you mentioned, I have had a number of roles as a medical educator and as a clinician. And I think, like many of us, as we have learned more and more about burnout, we have acquired a vocabulary that describes certain phases of our lives. And actually, I think many of us cycle in and out of it, or have cycled in and out of it throughout the course of our career without really knowing what was happening to us. But at the time that the story that I share in the book begins, so I had a random chance meeting in 2017 with one of two physicians who created a program at the University of Rochester that works with physicians, teaching them mindfulness skills. And this is an evidence-based JAMA published program that they've been working on for the better part of 2 decades. And so, at a time when I was having a number of major forces in my life sort of come to a head. I mean, one was my identity as an educator. Being a physician educator is so fundamentally important to me, because I believe that being a compassionate educator and creating a compassionate learning environment is one of the things that allows future physicians to be compassionate themselves. But I was finding that deep instinct and part of my identity was also running up against a number of other forces, including cultural forces, including forces that have to do with how we define whether a medical school is doing a good enough job, that dreaded accreditation process that we all have that requires everything to be either satisfying or very satisfying. And I had just come to question whether a lot of my original ideas about the kind of person that I wanted to be for my students was really just an illusion, whether I had been incredibly naive. And then at the same time, you mentioned all these other parts of my life. I mean, I'm the mother of 3 still fairly young boys. My spouse also has a fairly demanding career of his own. As a clinical teaching unit-based general internist, my clinical work would just engulf me for 2 weeks at a time. And then the third week, I would just basically need to recover from that. So I always seem to be going in and out of this cycle. And luckily for me, meeting this colleague interrupted that cycle. I went and did something that I can't even really say why I did it, because normally I think there are lots of times in my life where I would have said, this sounds flaky, this sounds weird, I'm not going to a retreat with a bunch of other losers in the woods. Like, it just didn't sound like something that I would normally do. But my experience at that retreat was profound and transformative. And probably the best bonus part of it all was that retreat gave me a structure and a scaffolding, not just for finding more joy in my clinical life and finding the way back into the rest of my life, but also for telling the story about medicine that I had been trying to tell and not really been able to find a way that felt resonant and authentic. So that was just a bonus byproduct.
So one thing that I really like, Jillian, is that moment where you're speaking with that physician after presentation, and he's nudging you along, and you're sort of let's say critical appraisal of going to Rochester, and but you went. So something inside of you surely was looking for something. I just as I read through your experience at Rochester, what was really connected with me was the relationships you formed, and the little groups, and the just wondering if you could sort of comment on some of those relationships, and how that I like, as you wrote about it really, I felt kind of disarmed you a little bit. And as you,
Yeah, that's such a great question, Damon. A couple of things. And just the first question that you asked, how that just meeting that colleague, the program leader, and sort of having, this skeptical kind of reaction. I think there is a really important fundamental truth there that allowed me to be open to the experience in the first place. And I think so many of us, when people talk to us about physician burnout and resilience and taking better care of ourselves, the gulf between that conversation and our deep unmet physical, sometimes, and often psychological needs is so great But the conversation, we don't even understand this originally, but there's a reflexive way in which that conversation actually hurts us. It feels that someone doesn't even know us, doesn't even understand the degree of our suffering. I often talk about we're drowning and they walk by you and they go, "Hey, great day. Do you want to, maybe like a rowboat?" And it's just totally discordant between needs and the outward perception. And so therefore, I just think this is really important framing when a lot of us go to something about physician wellness and somebody says, "Hey, I'm going to teach you to meditate," or "It's a free Chinese food at lunch." You sort of go like, "Are you kidding me? I can barely get through 24 hours of my life. And do you really think this is going to help?" So sometimes there's this framing piece. And again, it's not to disparage the efforts of the people on the other side, because so often they mean really well. Someone wanting to provide us with food, sustenance, that is so basic and so fundamental and so caring. But what it fails to acknowledge is our own reactivity, very often due to all the things that we have been repressing, piling on, learn to work through, learn to sort of even disassociate from in medicine, right? So that by the point that we get to the end of our residency program, many times we don't even know what we're feeling anymore. We don't even know what we need. So sometimes I think that reactivity is really important to acknowledge, because if we can call it into the room, give it a name, help people understand where we're coming from, and that we're not suggesting that this is a replacement for all the other things that need to change. That's kind of part one. But I want to talk about part two of your question, which I think is also really important. A couple of years ago, I was at the International Conference on Physician Health, and there was a speaker there from the University of Rochester, not part of this group, just coincidence, but part of an organizational psychology group there. And he made a statement that has always stayed with me. And he said, whether we know it or not, all of us want a more relational work environment. So even people who don't think that that's a problem in their immediate work setting, or don't really think they crave that, when you give it to them, they feel it. And so I think it's very interesting, going down to this retreat, I would never have said, yes, I'm hoping to go there and connect deeply with other physicians from around North America and make lifelong friends. I would have said, I'm going to feel better. And I didn't really have a sense beforehand of how profound and how meaningful those relationships would be to me. And I think there's also something really amazing that happens when we come out of our element. And, many of us will have gone to retreats of some type or program bonding retreats. Take us out of those usual places where all of our reflexive patterns of behavior and our defenses are normally just occur automatically. And when we go to a place where none of that is immediately accessible, sometimes even for a very short period of time, I think it can be really profound. We are forced to react a little bit differently. We're forced to behave a little bit differently, to consider things a bit differently. And the very last thing I'll say is I think part of the magic here, a retreat like this, people sitting and meditating together, there's something really wonderful that I've learned about that I always love to talk to groups of physicians about, because they tend to understand it. And it's the idea of the polyvagal response to meditating. So when we're doing any kind of focused attention practice like meditation, we're increasing our vagal tone. And if you and I are in a room doing a meditation together, my vagal tone increases. And then as a result, yours increases a little bit. And then mine does, and yours does, et cetera. So we get kind of this amplification of the part of the experience that's making us feel good in the first place. And I believe that that is one of the reasons why you can leave any retreat where you're meditating, but in particular one where we were really unpacking some of those difficult unmet needs that I talked about at the beginning. I think all those things together can combine to make the experience far more powerful than I would ever have imagined at the beginning.
Great, thanks, Jillian. I'm wondering if one of the other members of the team wants to jump in, because I could ask you questions for hours and hours. Yeah.
Well, given that silence is not a strength of mine, I'm not going to wait too long for my other colleagues to jump in. And for those that know me, they know that that's not my strength, but it's really, so thank you, Jillian. So lovely. I will confess I haven't read your book, but it is written down on my page and I will. But everything that you're talking about aligns so beautifully with what I have on this piece of paper. And recently, a colleague sent out, so I'm a nurse, and so we do experience the same things, and all have different challenges within our clinical experiences of the work that we're doing. But what she sent out was a document that shared something that another nurse practitioner wrote about the difference between fatigue and depletion.
Mm.
And and that's what you're talking about, because mindfulness or meditation is what works with depletion. So I'm just going to share some of it because I found it really interesting, because she shared that rest and relaxation alone don't restore our depleted inner resources, because we aren't just exhausted, we're depleted. And now we're in this pandemic where we've run to a place that is not just about being tired, it's about being depleted. And our usual channels of restoration are not readily available to us anymore so that we can fill them up. So what we normally got from human contact, we're not getting anymore, because sitting on this screen with all of you is awesome, but I'm looking at a computer screen that has faces, not persons that I can engage with. And so it's lovely because she asks us to consider an empty glass of water. And she says that you can rest that glass, for as long as you like, but the rest won't replenish its its content. And so similarly, our body and mind are just containers, and our emotions, our intellect, and our spirit are those contents that they need to be not just full, but overflowing in order us to not be depleted. So people go away on a vacation and they rest. But if they aren't taking the elements that they need for the depletion and looking for ways to fill up that vessel, that container, our intellect and our spirit, then it doesn't change. So I actually wonder, where do we all as a group fit in with that concept of fatigue versus depletion? And what are some of the tricks, and maybe Jillian, you can fill some of this in for us, that we can use with mindfulness, with meditation, with a restorative reflective walk in a park, or looking at something that will help us to not be depleted, so that we can work together in a much more healthy environment as a collective.
Yeah. And that is such an important concept that you've articulated. And sometimes in a mindful practice teaching context, and I think we might not have mentioned that one of the things I've done since this first journey down to Rochester is I spent a year doing a longitudinal internship at the University of Rochester, and I now teach mindful practice all over the place because I have found it so helpful. But one of the core things, a core concept that really ties into what you just said is the idea that well-being has to be about more than just escape. So escape, vacations, no matter how frequent they are, will never fix a fundamental imbalance, a dislocation, as Christina Maslach has called it elsewhere, between who we are and what we're doing. So it will never cure it. And I think many of our colleagues, even though they know that on some level, they've never actually put that into words. And putting that into words can actually be very powerful, because it forces us to look at our work environment, what is within our locus of control, and what things are outside of it that perhaps as leaders or as colleagues we can work to change. So a few things come to mind. I always one of the things I always try to say we're of course largely a group of healthcare providers, but whenever I work with people who are not healthcare providers, maybe boards of governors or organizations or things like that, the thing I tell them that I think is most helpful and most important for them to understand is that healthcare workers, for the most part, we speak in evidence, and doctors are particularly guilty of this. So even if, we say it's really helpful and a good thing when we're nice to each other at work, doctors go, well, that you say that, but show us the evidence, and you kind of go like, are you kidding me? I have to show you evidence that it's useful to be nice to people. But in fact, if we want to move the dial on a lot of these things, it's helpful. So one example of that, when we look at the literature on physician burnout, one of the things we know, and this is work done by Tate Shanafelt and a number of collaborators, if during the course of our work week, we can hit about 20% of work that we find meaningful, purposeful, and that gives us pleasure, we know that gives us some immunity to burnout rather. And that number is really important and a great number to start spreading around to people, because intuitively, if you were to ask someone and say, what percentage of work do you think you have to find meaningful and purposeful and sort of fill your cup in order to be happy and have immunity against burnout? A lot of people would say 80%, 70%, 60%, and it's actually only 20%. And what Shanafelt and colleagues found is that there is sort of a ceiling, because you might think, well, if 20% is good, let me try 25%, 30%, 40%. But the effect attenuates. It's 20% is kind of the ceiling. Less than that, you're at risk. So I love that number, because it feels achievable for most of us, right? If we look at a 5-day work week, and who here has a 5-day work week, but if we pretend that we do, that means that one day or 2 half days, if you can find work that is profoundly meaningful to you, working in a clinic with a population that you love caring for, colleagues you love working with and feel alignment with, that is going to have a big impact. And then a few other things that you talked about. We know, and this is not confined to work that applies to physicians, but we know the evidence and the science behind gratitude practices. A lot of excellent work out of the Mayo Clinic and other places showing that when we engage in some kind of systematic gratitude practice, we feel better. And the same thing for mindfulness. Lots of literature in physician health showing us that when we engage in, typically the literature calls them focused attention practices, to acknowledge that they're not just sitting on a cushion and meditating. They have a lot of different forms. But again, we get that benefit of vagal tone. Some of the literature has shown that we get improvement in people's mindfulness scores, which is associated with more emotional stability, and people feel more pro-social. They have more benevolence. And again, no real mystery there, right? Because we're increasing vagal tone. We know all the positive impacts of doing that, oxytocin, empathy. So those to me are sort of 3 conceptual things off the top of my head that when someone is saying, in my work, how can I fill my cup? Well, those are 2 evidence-based ways. And the third thing is just make sure at least 20% of what you're doing is deeply resonant with who you are. And that might be enough to get you through some of those times when there is not as much resonance.
That's a really good point to bring up. I like the 20% concept, because I think of that as 1 day a week.
Yeah.
In my only 5-day a week job that I have. but in saying that, I always, when I lived in Halifax, I remember having a discussion with my boss, my director at that time, about why I wanted to maintain a clinical practice. And the response that I received, I worked at Dalhousie, and the response I received was that, usually when nurses go to the university to work academically, they don't stay clinical. And I said, but that's where my heart is full. That's where I feel joy, when I can have patient care. And so when I did that, even though she told me I couldn't, I don't listen well. But when I did that, I would be at a shift, and I would be at a shift. And I would be present in that moment and with the people that I was supporting in their care, and felt that I was Erna again in another way. And so that I could go back to the academic environment and deal with some of the things that are not fun, but deal with them with a different state of being. So I love how you share it. And it doesn't have to be in clinical. It can be in a variety of different ways that people enjoy snippets of something. But the 20% is a good reminder. So thank you. That's awesome.
My pleasure.
I have a question, if we can go back to your comment about the polyvagal response of sitting with a group of people. And we work in an environment where we are sort of trained to deny things like hunger and fatigue and the need to go to the bathroom. And so we are a bit sort of, we've lost our bearings, because we are trained to deny those things and ignore them. And so could you speak about that, the sort of the opposite of the polyvagal response that happens when we are sharing energy? We're not sitting, we're not intentionally sharing the energy of people in our work environment, but are we? And how does that play out, and how do we think about and work with that?
Yeah, what an interesting question. Thank you, Shana. A few things come to mind. And the first is what you opened by saying, and this is a thing that I write about quite extensively in the book. I couldn't agree with you more. Part of our training is learning to be disembodied. So learning to hit an override switch every time we feel hunger, every time we feel overwhelming fatigue, and normally would honor our body's signals by having a rest and sleeping. Every time, or many times, when we feel overwhelming emotions. So not just tears, because some of us, I've always been a clinician who was never afraid to cry in front of patients, as long as it was in a way that they didn't need to manage my emotions. But the flip side is a lot of other emotions I've never felt particularly comfortable or safe expressing in a clinical environment. And many of us, we have no ability to articulate shame when we make mistakes, when people are critical of us, when we experience microaggressions in the clinical environment, or worse, when we just are made to feel that somehow we are inadequate, which is, again, such a fundamental part of our training. So we have this button, and we learn to push this button over and over and over. And it's just stuff it down, get away from it. I'm not feeling that. I don't have time for that right now. And then we finish our residencies, and we wonder why, when we come out of our residencies, we no longer seem to have any ability to read what is happening with us. So, you made me think of, too, another moment, sitting with groups of physicians and teaching this work now. And I certainly had this experience as a participant the first few times I went down to Chapin Mill. People would say, the session leaders would say, so where do you feel stress in your body? And my first answer was, well, I don't know. I don't think I do. How often do we consider that? How often do we notice? Again, because we've hit that override button for years and years and years. So we don't notice when we're hungry and we have a headache, and that's why we're impatient with someone. We have lost all ability to connect what's happening in our bodies, or not all ability, but a more sophisticated abilities that we probably had intuitively when we went into medicine, out of response that was initially adaptive and protective and becomes maladaptive. We have lost a lot of that. So a lot of the work, I think that, personally I have done in the last several years, and the work that I now teach and work with residents and medical students and faculty all over the place, is reconnecting with a lot of that, beginning at a much more basic level than we might intuitively think that we need, because we think of ourselves as a very sophisticated audience. And in many ways we are, as healthcare providers, but we don't necessarily have any more insight into ourselves than any other person would have into themselves when they start in a process of learning MBSR, or mindfulness-based stress reduction, or going through the process of therapy, or just, beginning to acquire more self-awareness. And I think just another thing that you said, so we talked about the polyvagal response, but the opposite is also true, right? So again, I've never seen literature saying if you're around people with low vagal tone, that makes you feel horrible. But we all know that stress and distress are infectious. So we all know the feeling, you're in a room with a colleague having a nice chat, and another colleague who never has a kind word to spare for anyone comes in, and we know what it feels like. We know that the air in the room, some clouds have rolled in, something no longer feels the same. And I think, depending on our individual work environments, some people do not relate to this happily because they have very high functioning, very emotionally intelligent groups that they collaborate with. I don't think that's the norm in medicine. And we also know from the literature that it just takes one physician, if we're only talking about physicians, it only takes one to create a hostile work environment. And the literature also tells us that between 2 to 4% of physicians have difficulty treating anyone in a respectful manner. So that's out of Gerald Hickson's work, I think, originally. So then we get to this question, okay, it's nice to picture the group of physicians meditating together and making everyone feel better, but what do you do about the person who walks in, who makes everyone feel the opposite of that kind of good space, increased vagal tone, benevolence? How do we handle that? And that is a big existential question in medicine that I've written about here and there, that I think is another one of the elephants in the room, that as part of culture change, we have a lot of work to do to address that as well.
Erna and Jillian, that was just a great thread. I see Willa's got her hand up. Do you want to unmute Willa and jump in?
Sure. Jillian, thank you so much for your time today and for writing your book. I absolutely loved it. And I just love, I think everybody should read it if they have a chance. I think you normalize just so many of our experiences that we all share in a way that kind of makes you so relatable at one point or another in our career. So thank you for that. And so I'm a community allergist in Kingston, and I actually attended your talk when you spoke at our Women in Allergy conference a couple weeks ago, and it was lovely. So I'm a medical educator at Queen's as well, and I recognize that many people on this call are as well. So as a medical educator yourself, and you shared some of your experiences in your book, I was wondering 2 questions. One, what practical tips do you have for us in terms of cultivating a healthier learning environment and culture for the students in the future? And, even if you don't have specific tips, do you have anything you would like to see in terms of systemic changes for the future that we could possibly work towards?
Yeah, what a lovely question. And thank you for that and for your kind comments about the book. So the first thing that comes to mind, we talk a lot about the learning environment, and it's critical, right? We've all known during the course of our training, there are fundamental problems with the learning environment that are historical in medicine, that are artifacts of a number of different characteristics of the way that we become physicians and institutions and hierarchy and privilege and all these other things. But we, in our turn towards fixing the learning environment, one of my strong biases, and maybe it is a bias, I don't pretend to be any more objective than anyone else, but I worry that in that conversation, we have not spent as much time talking about 2 other parts of the environment. And one is the teaching environment, and one is the working environment. So to me, I no longer use the phrase, or I try to no longer use the phrase learning environment. I try to interrupt people and say, can we reframe this as the learning, working, and teaching environment? Because it's an ecosystem. And I think that point, perhaps because of the nature and the evolution of the accreditation process, and it's an important process, standards are really important. Some degree of standardization in the experience of medical students across the country is desirable and critical. But I worry about something. And I worry about the recent shift towards making sure students are satisfied or very satisfied, because I'm not sure that is exactly aligned with what we hope to produce at the end of it. When we look at character, we all know we've had experiences that have helped build our character in a really positive way that maybe we're not the most satisfying. In fact, a few years ago, when I was an undergraduate at Western, I wrote a letter nominating a professor of mine for a teaching award. And I told the story in this letter of, that this was actually the lowest grade that I got in my entire undergraduate career. And in the first few months of taking this course, I thought this guy was just, off on another planet. He was so formal. He called us all Mr. and Mrs. Horton. And, so many of us just thought, oh, this guy is like 100 years out of date. It was much more fun to hang out with the cool philosophy prof with the ponytail, And so my first assignment, I remember getting a grade in the 60s and being, just aghast, and then being able to look a little bit deeper and saying, wow, he is right. Everything that he said in his feedback about this essay is right. And getting to know this professor, achieving the lowest grade on my entire undergraduate transcript in 4 years, and feeling that that person had imparted the most to me. So at the time, if you'd asked me, and many of my colleagues maybe who would not have been, or my fellow students maybe who wouldn't have been so tolerant of what that person was trying to teach me or elicit from me, people might have said that his course did not meet their standards, that it was not satisfying or very satisfying. And a professor like that might not even be able to have good evaluations at a medical school right now, and particularly a female professor or a person of color, because we know that the literature tells us that often those individuals with those characteristics are praised more harshly. So it's really worth taking a step back and thinking about have we actually shot ourselves in the foot with the entire way that we frame student evaluation? And this really worries me because I hear more and more and more from fabulous medical educators. I don't know what role I want to continue to have in medical education because I give someone a bad evaluation. They, weaponize their evaluation in return. The exact thing that we're trying to protect the students from has now moved and shifted, right? So these are really difficult conversations because, again, there's a hierarchical perception there. We have tended in our focus on the learning environment to buy into a model, which is often very true, that the student is more vulnerable than the faculty. But it is not always true. And it is, again, a very messy concept. We like absolutes, we like dichotomies, and it is not a dichotomy. So if there's one thing that I hope in the next decade in medical education to see, it's a shift from that framing of more of a human resources, customer satisfaction mentality towards just really making the students feel that they are engaged stakeholders in the outcome, but not that the outcome is their satisfaction, that the outcome is the environment they're going to be graduating to. The educational life cycle when we're residents and medical students is so short, right? It's a fraction of our time as a physician. And so really enlisting them to doing that. I don't know that that really answers your question, but it's more of an existential perspective that I think more of us need to be adopting as medical educators. And I continue to believe that profound compassion towards our students continues to be one of the most important tools we have in shaping their identities. But we have this other kind of dual track problem of them needing to be satisfied. And so I like to have these difficult conversations with students and learners and help to see if we can get them to reframe their thinking as we're here to serve them versus we are all here to serve. How can we make that more meaningful across the board?
Jillian, I really appreciate those thoughts on teaching and learning. You talk about the learning, working, and teaching environment. I'm just going to pick up on the thread of environment. And earlier you spoke of relational work environments. Mm-hmm. And, we work in teams so much of the time, and not just our own discipline, but these interdisciplinary teams. And just, can you comment on how teams can build wellness? You've spoken a lot that we can do for ourselves, and just sort of thinking about teams, because we often forget, as we're sort of grappling with our own burnout, that our colleagues are feeling the same potentially.
Yeah. Such an important question. So a few conceptual answers and then a few more concrete things. So one is, the power of psychological safety. And we all know it, and probably many, if not most of us, are familiar with Amy Edmondson's work out of Harvard and how her work before she coined the term of psychological safety was with medical teams. And she discovered that the teams that made the most errors seemed to be the ones that got along the best. And she was sort of bewildered because this went against her hypothesis. And then she realized, wait a minute, it isn't that they're making more mistakes, it's that they're actually comfortable to share their mistakes. So I think it can be helpful for us to articulate that psychological safety is not only one of the things we're after when we look at how teams relate to one another, but also that we know that it has important positive impacts on patient outcomes, that it isn't just about all of us. Again, it comes back to that point, doctors need to speak in evidence. So reframing for people that, yes, this is about us being happy at work and feeling better working where we work, but we know that we take better care of patients when we have that. Therefore, institutions and leaders can't turn a blind eye to settings where it doesn't exist. So what kinds of things are actually helpful? Well, a few come to mind. One is a strategy that I've learned in mindful practice and that I now use a lot teaching in mindful practice, and that I've actually trained. Right now I'm working with a group of pediatrics residents, mentoring them, doing their ice cream rounds. I hate the name ice cream rounds, but regardless, I've accepted it because they like ice cream. And every month they do a session using a structured conversation technique that I originally taught them, and then I attend the sessions and give them feedback afterwards. It's so much fun. But really, it's creating in these rounds a period of about 20 minutes, and each person gets a prompt. So they're asked to narrate a story in a particular way. And sometimes it'll be a positive story. Sometimes it'll be about something that they did that they're proud of clinically. Sometimes it will be about a difficulty that they navigated successfully, an interpersonal problem. And their colleague is instructed to simply listen. And they're given a more detailed directive in terms of how to deep listen, how to not interrupt their colleague at 3 minutes to say, oh yeah, I know I had a case just like that, blah, blah, blah. So really giving people a structured way to create those conversations. And one of the really lovely things I find, especially working with PGME groups, is they say, wow, I had no idea that I was such a bad listener. And I had no idea that I interrupted people so often. And wow, it actually felt really good to tell a story to my colleague, especially about good things. How often do we go into the doctor's lounge and say, well, let me tell you about something a family just said to me that made me think, I must be really good at this. We go and we sit down and we say, oh, I blew this. This went wrong. I missed this. That's what a lot of us do in our sort of with our confidants. So that is one way, creating in a consistent way at the beginning of meetings, at the beginning of rounds, during teaching sessions, teaching that speaking and listening technique, which is also really applicable to clinical environments and patient care, but it builds benevolence, and it's another thing that people often say at the end of these workshops and exercises is just how little it takes to feel close to a colleague, to suddenly have insight into another colleague's vulnerabilities, their weaknesses, their own self-doubts. And then there are a few other exercises that I tend to be fond of using in a clinical setting. And one is, it's just something that I do. It's not anything I learned anywhere. I call it changing places. So especially when I have teams that are struggling, we sit down under the pretense of having a teaching session. And then I ask each person to imagine that they are a different person on the team. So the resident has to imagine that they're the medical student, and the IMG has to imagine that they're the R3. And they have to try to talk about what's difficult for that person. And I find this is really effective in team settings when the relationships are not strong, when people are really struggling with frustrations about the other person. It's very hard when we activate the compassionate imagination in that way to not leave that experience with more sympathy and benevolence towards one another. And it is one of my best cures for teams that are not working, because it suddenly makes people realize, even with a little bit of guilt, that they actually have not been having any empathy for the other people. And again, I like it because it deconstructs that hierarchical idea that the R3 can only abuse the M3, and the R3 has everything and the M3 is sort of infantilized in that structure. And it makes everyone think in a more sophisticated and emotionally intelligent way. And then sometimes, just the last thing, using framings that are, I love cognitive error. I love talking about cognitive error and teaching about metacognition, which of course is very tied to mindfulness. So I love talking to groups about, we just had this experience with this person, or we just had this difficult interaction with this person. What else could it be? What else could be going on in that person's life that they were, a bit sharp with us on the phone? And again, I'm not talking about excusing racist comments, homophobic comments, misogynist comments. No, that zero tolerance, totally different. But just the interpersonal difficulties that we have, the hard moments, the impatience with one another, the things that are really endemic in our specialized environments, but should not be labeled as harassment, should be, again, that's another problem I see, that we've given this vocabulary of calling, difficult interactions, moments of disrespectfulness, moments when people could have been more attentive or more thoughtful. We call it now abuse, harassment, etc. And we've eliminated the discernment part of that. So again, not suggesting that this is easy. It isn't easy. It's a hard slog. It's actually much easier to be dichotomous, but that is another thing that I find very helpful with examples. So I love, and this is the last thing I'll say about this, when we have a difficult moment with a colleague, I love to tell stories with my teams or my coworkers about times when I made false assumptions. So, recently I'm working with a group. We've been doing a lot of advocacy here about COVID, and we're all sort of unlikely bedfellows. Many of us are people who have worked together in different ways before, but never known each other well. And I have one colleague who I wasn't feeling well a few weeks ago, and there was something that needed to be done. And I messaged this colleague and I said, do you think you could do this? I'm just not feeling great. And the colleague wrote back and said, sorry, I can't. And I got under, kind of hot under the collar, just to myself. But I thought, oh, you know what? He thinks I should do it because I'm a woman. He thinks that I don't have anything. He doesn't know that I have 3 young kids at home and this and this and this and all that kind of, I noticed all that cycling in my mind. And it's also interesting to note, this is a wonderful colleague. I mean, a colleague I really have really positive feelings towards and a lot of warmth. But what's interesting is a little while later, he messaged me and said, sorry, I couldn't respond in more detail. I just, one of his siblings had died suddenly and unexpectedly 2 days earlier. So what else could this be? There's that big Venn diagram. I'm sure you've seen it. There's a little dot, what other people know about you. And then the big circle is your whole life. So that kind of framing, I think, brought forth with our own narratives, our own examples, our own willingness to step forth and to tell stories just like the one I told when I made a false assumption. I think that's another really powerful thing we can do with our teams, with our learners, that moves us towards a more compassionate culture.
Jillian, I'm going to just pick up on a few points that are in the chat. I've got one message from a colleague saying how your words speak to her heart, which she sent to me. But earlier, Elizabeth Eisenhower, when we were talking about evaluations, and you were talking about that professor that gave you the lowest mark, Elizabeth says, maybe a better question is not about satisfaction, but about growth, and
yes.
Growth is what we need to pursue, and it can be uncomfortable at times.
Yeah. Yes.
And how do we get after evaluating growth versus, as we were saying, sort of satisfaction?
Yeah.
So,
I think that's an absolutely on point comment from my perspective. And, at the end of the day, I think it comes down to all of us as medical educators, whether in all the allied health professions as well, not just medicine, being willing to have those difficult conversations, because what I see a lot of the time is they are avoided. They're avoided institutionally because the cost of not getting accreditation is obviously devastating to everybody who is a devoted medical educator. It feels like a real personal failure. It's humiliating, all those other things. And the way I sometimes frame it, when I'm trying to enlist students as allies in a bit of that reframe, to just reject that concept that the faculty is here to satisfy them, to meet every possible need that they could have, and that all these needs are somehow equal. I talk about it as, if we don't have these conversations with you, when you are in our shoes, the problem will either be the same or worse. And we cannot avoid the difficult conversations about medical education. I sometimes compare that to the idea of, just fumigating one room in your house for bed bugs. It's not, we are saying as a profession that we need culture change. We are recognizing that so much of what we are doing is not working. It isn't serving us. It isn't serving organizations. It isn't serving patients. And so we cannot have a more honest standard for dialogue in one part of that conversation than all the rest of them. We have to, again, be willing to go to those difficult places. And I just love this idea that instead of satisfaction, growth. Did this person help you grow in a positive way? Is a question that, does not suggest that their job was to please you, or that the relationship was, passive, that you were just the recipient. So that's a wonderful point.
Yeah, it really speaks to the developmental trajectory and growth mindset that as educators we're after, which great.
Yeah.
I'm going to also bring up Tammy LaRiche has a question for you, Jillian.
Mm-hmm.
in the chat, she said, what is your opinion on expecting humanity/compassion from patients? You've been up all night, you're running from clinic to clinic, you might be slowed down. She's asking,
Yeah. Another great question. Now, this is an oversimplification, and it does not apply in certain contexts and certain relationships. But my perception is that in general, when we give humanity, we receive humanity. So when our patients know us as compassionate, caring physicians, my experience, the majority of the time throughout my career has been that they actually do in return have compassion for us. And I also think if we don't show people our humanity, it makes it very difficult for them to see it in us. And this is another, Damon and I have talked a bit about our mutual feelings about our misgivings about the word of professionalism. And a lot of how we have taught generations of learners recently to understand their professional identity is using this word professionalism, which sometimes in the wrong hands can be taken to mean leave your personhood at the door, interact with your patient the way the bus driver or accountant speaks to you, instead of, again, really focusing on, sometimes the concept is called hostmanship, creating a warm and invitational space wherever a patient is. But my feeling is that sometimes, I do see this with colleagues. And again, this is recognizing that there are so many variations on this situation, and lots of times where we have deep compassion for our patients and we encounter someone who is intolerant of our errors or our lateness. And, that is part of I think, one of the deepest sources of pain that we experience. I share an example of a kind of scenario that many of us have experienced in the book, where a patient blames us for something that has gone wrong that isn't our fault. And it's, kind of boils down to that same idea, the feeling, the profound pain when someone thinks something about us that is not concordant with our perception of ourselves or some of the realities about our personality. So very hard. But again, I think there's a real case to be made for the more we can show ourselves, describe something about our lives, the realities of it, let people know, that we were up all night, that we are being run ragged in the current situation, that we're grateful to them for waiting for us and showing us compassion in those moments. In high functioning relationships with very relational individuals, I think that can neutralize a tremendous amount. And to me, that is still one of the best weapons. And just the last thing I'll say, when I started medicine, as those of you who have read the book, my identification was with patients. It wasn't with physicians. I went into medicine because I saw myself as kind of a renegade, a maverick. I wanted to be all the things that certain people in my family's life, caring for my disabled sister, had never been, and had failed to deliver. And over time, one of the things that really came quite by surprise for me is the amount of compassion that I went on to develop for my colleagues, even some of my more difficult colleagues, and how I began to see some of the things that I had attributed as personal failures as the product of a very dysfunctional system in so many of the ways that we talked about. So I really still identify deeply with those patient concerns, but I also feel that part that you just described, that it's really important for us to be transparent about our experiences so that we can help other people have more compassion for us and help us as stakeholders and advocates to achieve some culture change.
Great. So Jillian, while you've been chatting the last few minutes, Tammy and Elizabeth have both sort of written some follow-up in the chat, and I'm just going to read it out for a minute. And while I do that, I ask others in the audience, because I've had many chats with many of the faces and names that I see here, for others to sort of jump in with a question or comment. But I'll just first say, so Tammy LaRiche, who was asked a question about sharing compassion, humanity with your patients, said that she wrote an article and submitted it to a national journal, and was the editor stated that physicians should not exert compassion or understanding in that way to their patients. And her comment is, how do we move forward when you know, some in leadership, whether it be a journal editor or somebody else, are sort of propagating this, you know, not to share anything back.
Yeah, can I just say one thing,
Yeah.
a couple of things about that, actually. So number one, I think you actually, in that little blurb in the chat, have your next article, because this is a great starting point for, if a journal says this, and you don't have to call out the person, it can just be an article about any journal, right? But if that's the feedback, you know, again, to me, this is one of the best ways that we challenge these messages. We take the feedback, we reflect it out to the rest of the profession, and we say, is this true? Because when we see, look at what happened with JAMA, right? The horrible comments made by one of their associate editors about, you know, no physician is racist, the totally tone deaf comments. I mean, there was a real reckoning there for them. And I'm not so naive that I think it's necessarily going to have the impact on one individual's career there that, you know, they'll land on their feet again. But regardless, there was a resignation of the editor-in-chief, I think. And so it just says, you know, when we reflect back, here is what you said, here is what the rest of the profession says about this. It can be impactful. You know, we do see, and we've had other episodes that I can think of even in Canada, you know, about an article that was Andres Lapakis, who I think so highly of, who is a wonderful individual, apologized for an article that was published in the CMAJ about how women should handle microaggressions in the workplace. It was a tone-deaf article. It was a poor choice to publish it. The feedback arrived loud and clear, and the journal responded accordingly. But the journals will not do that without that big mirror that we have to be brave enough. And I know it's difficult. I don't mean just be braver. I mean that we have to find the collective strength together to hold up, prop up this big mirror and say, look at this. This is no longer who we are. This is actually just your opinion. And it's reflective of the dogmatism in medicine that tends to characterize us. It's not a fact.
So also in follow-up, Elizabeth Eisenhower, who's been around a few years and had numerous leadership roles, as a medical oncologist and other, her comment in the chat is, you know, talks about when you anticipate what the patient and family might be feeling, and you acknowledge it ahead of time. She's saying, you know, that takes them from annoyance to understanding and completely changes that dynamic. And I know that in the emergency department, for me, one, you know, I have different things that I say to patients and families, and I'm a very chatty person, and so I'll not infrequently say, I would love to stay and keep chatting, but I got to run, and I'm going to be back. And if something changes, you hit your bell or you let the nurse know, and I'll be right back. But I'm going to see in a little while when your stuff is back. And I've learned over time that preemptive little bit of asking to be excused or apologizing for lateness makes a huge difference. And it is nice to see that others are feeling, feel similarly, and do not agree with that editor that Tammy encountered.
Exactly.
Yeah.
So Damon, maybe I should speak to some of the things I keep saying in the chat. I think thank you firstly, Jillian, for writing as you have done and for sharing some of your experiences and thoughts. I would have a couple of reflections. One is that nothing diffuses a tense environment more than acknowledging and accepting your part in what's gone wrong and it's very hard to switch from wanting to defend yourself to falling on your sword where it's appropriate. It is amazing how that takes away a lot of the tension in an interaction. And one of the things I did with trainees in oncology when I had my brown bag lunches with them was we talked about what to do when a patient complains about you, or when you're facing that sort of antagonistic thing, is to find the bit of it that you can own and upfront just apologize for it. We all know that it's very hard to do, but it makes a big difference. I also wanted to raise, and I just wrote this in the chat, the most challenging part of my interactions with patients over the years have been when they have said or through their behavior indicated that they were unhappy to see or made derogatory comments about someone who was a visible minority or a woman or a person of color. And I know a lot of our colleagues wrestle with, in a patient-centered environment, how do we respond to that? Do many people just ignore it as if it wasn't said? I feel that's wrong, and yet it's not likely in a patient encounter I'm going to reframe somebody's ideology of 40 or 50 or 80 years. And so what I have said is, I'm not comfortable when you speak like that in our clinic, and I just want you to know that, and then move on to what we're going to talk about. But I really appreciate some guidance, especially given the preambles to this session that Damon shared, about how others choose to manage or not manage those instances when they come across them in their lives, and yours as well, Jillian.
Yeah, thank you for those comments, Elizabeth. They are so insightful, and they really speak to, again, just care with that, thinking of ourselves at the same courtesy that we would extend to anyone. If we have a meeting with our accountant and our accountant keeps us waiting, we expect our accountant to say, thank you so much for waiting. Or if there's a reason for them to apologize, and just acknowledging our power to de-escalate and to, with our authenticity, to really take some of those things out of the room. I think your comment, this latter portion, is so important, because so often, and especially this comes back to our role as medical educators, our students are looking to us, just the way our children look to us when we are out in public and we hear a racist comment. They remember what we don't do just as readily as they remember what we do. It is profoundly important to them, and is, again, a big part of that psychological safety, whether more so, especially for those who may be members of racialized groups, or maybe there's a gender reason why a comment is made. But regardless, people, when we miss those moments, and when we do not develop a more sophisticated approach over time and have sort of a plan for dealing with them, I think there's a way in which our learners can feel abandoned. So I think, the way that you have suggested is one excellent way. And I often, have sort of scripted comments like this in mind that are not confrontational, but again, I think of it sort of as achieving containment in the environment, just the way we talk about that in the psychotherapy literature or with children. It is our job to create and hold that space. So one of the ways we do that is by setting safety limits for people and saying things like what you said, I'm not comfortable with you speaking that way in the clinic. Or if a person makes a comment that they don't want a particular team member caring for them because of their characteristics, I have said to people, that person is a valued member of our team, and they are just as important on this team as I am. They will continue to provide you with the best care that they can, the way I will. And what we ask of you in return is to be respectful and kind to us. And I will also, if a team member has ever experienced, and particularly thinking of my years and years on the clinical teaching unit, if someone ever just says, I don't want to deal with that person or see them because they've made, typically they are gender comments, misogynist comments, just the most common things that people will say openly, or the female learners might feel uncomfortable with someone, I will always say, you have every right to say no. Or sometimes I'll say, I'd prefer that you not have to deal with this patient again, because his disrespect is pathologic, and I don't want you to be exposed to that. Is that okay with you? And sometimes really being careful with my learners that I'm not framing it as they're being pulled because I don't want the patient to react to them. Really being clear that when I do that, it's for their well-being if they want it, not because I don't want to, upset a patient who has made racist remarks, etc. And, the one other thing, I think this is a given, but we all know that sometimes, especially on like internal medicine wards, some of our patients are say these things in states of dementia, and again, sometimes, again, just talking through when comments like that are made, never pretending that they didn't happen, and talking through the team afterwards about, what it felt like to hear that word coming out of that patient's mouth as we were in that room with them together, as opposed to necessarily responding in the same way that we would if the patient were totally cognitively intact and choosing to make a remark of that nature. So I think just the most important thing is exactly what you articulated, trying to find ways that we know when the moment occurs that we will say something. And again, knowing that that's part of how we create containment and psychological safety for our team. Actually, I just see another comment there. Excusing bad behavior is not related to patient-centered care. Totally agree. And another corollary of that, another interesting one, if we look at physician behavior and difficult physicians, advocacy doesn't give us license to behave in a disruptive manner. So there are lots of examples of places where, there's no bad behavior free card. And if you're delirious, we'll handle the situation differently, right? But that's exactly right. This is not about making excuses for the patient in those situations. Our primary obligation is actually to keep our team safe and to keep ourselves safe and identify the behavior as opposed to just letting it be the elephant in the room.
Anne, you had a number of great comments and observations in the chat. I was wondering if you wanted to unmute and jump in.
Sure, thanks, Damon. So I'll preface my comments by saying that I've jumped from being an educator to a patient advisor at our local hospital. So I'm on the other side of the gurney now after 40 years in healthcare, and it's quite a different point of view. And I just want to say that rude behavior is rude behavior, and I don't expect that from anyone, whether it's a colleague, a professional, or another patient. So I agree with your comments about that. But I wanted to contribute in a really positive way by saying those small moments of compassion leave such a huge mark. And I know that more now than ever. I had surgery during the pandemic, and in my mind, that's not the ideal time to be in hospital or to be facing surgery. And as I was lying on the bed in the OR waiting for the anesthesiologist to put me to sleep, he asked me how I was doing. And I addressed the whole room and said a few comments that I tried to make humorous. But I said, just take good care of me. And his reaction from over the back of my head was to put his hands on my face and to say, you are in the best care. And I can't tell you, it brings me close to tears now every time because it was so powerful. And it took seconds. And I've shared that story with many, many new staff in orientations around patient-centered care at the hospital. And I've had much great feedback about that.
Yeah.
I also will end by saying I shared it with the anesthesiologist afterward in a note of thank you. And he responded with a full-page email to say, I never get thanks. I don't expect thanks. I was just glad to do that for you. But thank you for telling me because that's made my day. So just to share those moments of compassion, they go both ways and they're so powerful.
So true. And, and there's a story that I share in the book towards the end about my surviving sister. One of her encounters, she was about to have surgery, and a very similar encounter that a anesthesiologist just saw her in that moment as a human, said a few short words of comfort, and the profound, long-lasting impact. And this is, a big thing that I've lived through as a family member, that you understand that. You made me think of one more thing. And, the Cleveland Clinic has done such wonderful work, as I'm sure you know, as a patient advisor, on really reframing and making accessible some of the concepts of the patient experience. And there's a formula that I think comes from their work, if I'm not mistaken. And the formula is heart, head, heart. So when you first see someone, to say a comment from the heart, It's nice to see you. I'm so glad to see you again. I've been wondering how you were doing. And then we go back to the head and we talk about the intellectual content of the appointment and the medications and all the other business that we have to dispense with. But we end again by going back to the heart. It was so nice to see you today. It was just such a pleasure to catch up and hear about how everything's been going. I'm really looking forward to our next appointment. And, it's a formula that many of us, if we're emotionally intelligent, if we love our jobs, if we're compassionate, we do it anyway. But what a difference it makes. It just changes that tone. So, and it's again, what I like about that, it's so accessible to learners because, sometimes we'll be watching them with patients and we'll be trying to give them feedback about how to improve. And they're maybe a little awkward and some of that doesn't come naturally. So if you say to them, let's try when we go to the bedside, each bed when we round today, I want the team to start with heart and then move to the head and then end with the heart. And you can just feel there's a change in the quality of those rounds. People are just more thoughtful. They're more aware of what they're saying when they arrive at the bedside, because usually they go right to the head, or the how are you today is so perfunctory. It's like it didn't even happen. So that's another way I find for us as educators that we can incorporate some of what you just so beautifully described in terms of how the impact and the importance of heart in those interactions.
Thanks, Anne and Jillian. That was really great. So, Jillian, we just have a few minutes left of our conversation, our time together, and it kind of dawned on me a few minutes ago that you spoke of your professor from long ago who promoted a lot of growth. We happen to have another professor here, former Principal Daniel Wolf, who was also one of your professors, if I understand correctly.
Not exactly, but there is it's a connection. I can let him tell the story, actually.
I'm just going to invite Dr. Wolf to jump in.
Hi, Jillian. Welcome
so
virtually, nice to see you again. I'm here with my spouse who prefers to stay off camera, but great talk. No, I am not one of Jillian's professors. I would dare say I've learned a lot more from her than she would ever learn from this early modern historian. But our connection is actually originally a non-medical one. First of all, we're both from Winnipeg, and although I left long before, the other one is that Jillian kind of hides her light under a bushel. Apart from being a fabulous writer and educator and thought leader, she is also, if you read the book, an extraordinarily talented musician, and I hope she will not mind my saying that. I first got to know her work as a musician, not as an MD, and it was a great surprise to learn that this fabulous singer and pianist whose music I've played on my jazz show on CFRC was actually the same as the Jillian Horton, the medical educator. So we sort of got in touch and exchanged tweets and so forth. And we know a whole pile of people in common from Winnipeg and my old high school. So we have been looking forward to this particular talk for quite some time. Have Julie and I were sorry I couldn't be in person, but this is the COVID world we are in. I did want to just say a big thank you to Jane and to Damon for having arranged this. I think this sort of originated in a couple of exchanges that Jillian and I had, and then as principals and former principals do, I let other people do the actual work of setting it up. But great talk, and I hope others got as much out of it as we non-professional, non-medical types did. But a lot of it, I think, was applicable very much to other fields of teaching than simply medicine. So thank you very much.
Oh, thank you. And when you speak and we finally get to see each other like this, and I know we'll get to meet in person in the future, but you just make me think of this, when we are doing the work that we really believe we are meant to do, doing it full-heartedly, authentically, we find our co-conspirators, they find us. We just find the people with whom we share values and alignment, and by coincidence then, other friends and other people. And it's just such a curious thing. I find that the more we do what we feel we must do, as opposed to follow the usual path, for the typically scripted life in medicine, it's just very interesting how we find our people.
I think it's what some German writer of the Romantic period, I think, called elective affinities.
And the other fun fact that, in terms of all these random Queen's connections, is Patrick Dean, who of course can't be here tonight, Principal Dean, but was one of my thesis advisors as a student at Western. So, boy, am I ever, I've said to Damon before, I am very jealous of all of you at Queen's, because clearly you have all the energy in the universe that is related to things I love and believe in, and so much humanity. So thank you for everything, Dan.
Yeah.
Well, Jillian, on behalf of the team and everybody here, again, a really big thank you and a big sort of virtual hug out to you. The two things, one came that I really, other than enjoying all of this conversation, the 20% really hit me up front, filling your cup. The 20%, we won't count weekends, but that one, one day or 2 half days or whatever, I certainly feel in my clinical practice, like just every shift, I just need one little tidbit that I can grab onto. That really speaks to me, and that low threshold of 20% really seems achievable and is a good sort of frame shift. And then what you just said, that co-conspirators, makes me a little bit nostalgic or reflective on the year that we've had of our series. You're sort of bookending the end of the series, and I'd like to say to everybody who's still on the call, I'd like to call all of you our fellow co-conspirators, and hopefully you'll keep traveling with us when we come back in the fall for our second year of the series. It's been great having all of you come to these sessions and participating and building community. It's really been fantastic. So thank you, Jillian. Thank you to everybody. Erna, Shana, Catherine, Hugh, any last parting thoughts or comments?
Just thank you very much, Jillian, and it's so lovely that you were able to join us tonight.
It really was my pleasure. Thank you to all of you for creating and making this space for this kind of dialogue. It is, my friend Mick Krasner talks about bidirectional healing in our patient encounters, and it's the same for these kinds of experiences. They're only possible because everyone comes together with some of the same things in mind. So thank you so much for the opportunity.
Jillian, I would just like to thank you very much. I was itching to jump in so many times because I've shared so many of these experiences, and I think I agree with you on so many of the points, Jillian, but that's why I didn't have a question. But one thing I would say is that consistently when I have been in a hospital, and I've been in a lot in the last 20 years, 95% of the people I've dealt with at KGH have been wonderful and compassionate and caring and all the things that we've talked about. But there's still that 1 or 2%, which I find more difficult to deal with because, I'm so dependent on that caregiver as a quadriplegic. And this last 10 days being there alone and sometimes getting a nurse or someone who wasn't compassionate made so much difference. But then, sure enough, at a different shift, another person would come in and they were just the opposite and so nice and caring. And it's so easy to be like that. And all of a sudden you remember, you just can't let that small percentage make it miserable. And it's not worth complaining to anybody because you know that the majority want to be caring, and they are. But there is consistently one or two that could just really make it miserable. And I think I would be more vulnerable because of my situation, especially so during this pandemic. And it applies to everybody. And I look around in the room and everybody had bad things going on, but I found this time, you know, the one or two bad people really made it a tough go this time around. But thank you so much. That was as Damon said, one of the best, you know, bookends to this lovely series. So thank you very much.
Thanks, Hugh. Thanks, everybody. Stay safe, be well, and go fill up your 20%.
Thanks, everyone. Good night. Bye for now.